Anyway, respiratory system, or pulmonary system, same thing. We'll just do the basics, some vital functions that probably more or less you know a little bit about. The functions, it brings in oxygen into the body, expels the waste product after making ATP as CO2, carbon dioxide gas. And it's also going to help regulate acid-base balance. It's not a good topic that students like, but it does deal with chemistry. So this is why I find that putting the respiratory and the urology subjects all in one on the next exam, because you're going to see the acid-base balance is going to be controlled by the two of them. I find that it's probably the most important system in your body. The heart and brain need a continuous amount of oxygen supply. You better make sure that those lungs are functioning, bringing in the oxygen there. No breathing for 3 to 4 minutes, you know you got irreversible brain damage. Also, when they do vital functions, respiratory rate is one of the 4 vital functions, or the vital signs rather. So when a nurse comes in to check a patient, she's checking 4 different things. One of them is the respiratory rate. Now, she doesn't just count it and ask you what's going on. She watches your chest go in and out. But what are the 3 other vital signs? Do you know those? What are the other things that this nurse comes in to do all the time? Heartbeat, heart rate, blood pressure, and temperature. Right? So respiratory rate is one of the 4, right? Okay. And as you know, respiration is an integral part of CPR, right? Cardiopulmonary resuscitation. And we'll talk about that a little bit later. Those are our vital functions of the respiratory system. Now, let's do the easier part, the anatomy of respiratory, which isn't so bad to understand. Basically, it's broken down into 2 parts. We have the upper respiratory and lower respiratory tracts. So we have in the upper respiratory, we have the nasal cavity, the sinuses, and the pharynx. The pharynx is the back of the throat. And just below the back of the throat, we have something called the larynx. Everything below that is going to be the lower respiratory tract, which is going to include the windpipe, which is better known in anatomy class as the trachea. And that's going to branch off into 2 things called bronchi. And then the bronchi will turn off into smaller branches called bronchioles until it finally gets to the lungs, which we have tons and tons and tons of these air sacs, which are called alveoli. So we can have an upper respiratory tract infection and a lower respiratory tract infection. Are we so distraught with someone having an upper respiratory tract infection? Not so much. You know, you could have a runny nose, you could have laryngitis, pharyngitis, sinusitis. They can cause problems. The biggest problem we're concerned about is that if it spreads down to the lower respiratory tract. That's where you definitely don't want anything to happen, because that's where our gas exchange takes place. So that oxygen could actually come off the lungs into the bloodstream, and carbon dioxide could come off the bloodstream and go into the lungs. So that's what we're concerned about. And if the alveoli ever get infected, then we refer to that as pneumonia. Okay? So it's just showing you here. Again, you have the nasal cavity, you've got the pharynx back here. Underneath that in the area is the larynx, leading to the trachea. You've got the 2 bronchi, and then you have the 2 lungs, which contain tons and tons of these alveoli, or air sacs. Okay? There's the parts of the nose. Any questions? No? Good. All right. So now we have we have the sinuses. Okay? And you learned that from A&P1 that 4 of the bones in the face have the sinuses, which are air areas. So basically, they're air sacs in the bones. The frontal bone, the ethmoid bone, sphenoid bone, and maxillary bone. This is the reason why we have this, is that when you breathe in air, if it's a cold, cold day, that air that's coming in is very cold and dry. And if that immediately hits the blood vessels in your lungs, they will constrict and you're not going to be able to breathe. All right, you'll go into a shock. So we need to somehow be able to moisturize that air, and also warm up the air before it gets into the lungs, so it's more efficient for gas exchange to take place. So what happens here is that we have these sinuses, these air sacs throughout the certain bones. They're there for two reasons. One, pretty obvious, they're making your head lighter. All right, they're not so. If they stay solid, then you're going to need muscles like Arnold Schwarzenegger to hold up your head, right? Because it'll be so thick and so dense and heavy. But the other major reason is, again, it's going to be these sinuses are lined with pseudostratified epithelium, and there's a lot of goblet cells there also. All right, as much as we saw goblet cells in the digestive system, we have it also in parts of the respiratory system. The goblet cells are going to secrete what? What are they going to secrete? What does goblet cells secrete? Come on, guys. Goblet cells. Mucus. Mucus. Bingo. All right. Good. All right. So it secretes mucus. As it secretes mucus, as the air that you breathe through reaches the mucus, it's going to moisturize the air. Moistened air is easier to manage in terms of gas exchange. Also, the lining of these sinuses is loaded with blood vessels. And as you learned, blood itself is about a half a degree higher than the rest of your body. So as the cold air comes through your nose, it's going to also warm up the air before it gets down into your lungs. All right? And that's the theory. I don't know if it actually works, but that's the theory why people tell you to, as you're running, to breathe through your nose and exhale through your mouth, so that you could actually make the air that comes down into your lungs more efficient for gas exchange. It runs through there. Okay? So let me ask you this really quickly. Why in weather that has 0-degree weather outside, your nose runs? Which I never understood, right? If your nose runs and your feet smell, it should be the other way around. But why is it that your nose runs in cold weather?
Because your sinuses are overstimulated.
The goblet cells are overstimulated. There's a lot of dry air coming in there, so these goblet cells are going to be actively stimulated, and it's going to produce a lot of mucus. And that's what's happening with that. Okay, so it makes sense. All right. So the nasal cavity, there's a nasal septum that separates the left and right nasal cavities. There's the conchae, or also called turbinates, and that's just going to give you more more surface area. This is, let's say, your nose over here, your cavities for your nose, and there's a septum. And you've seen this in a skeleton, right? But what will happen here is that air can actually come on to here. But what if we are able to create these shelves? These are called turbinates or conchae. Okay? And what's happening here, sure, we could have absorption happening here, or surface area here. But now we've got surface area here, 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 and so forth. We're increasing surface area so that when we breathe in, we have a lot more area for that, let's say, because this is all lined with pseudostratified epithelium with goblet cells. So you have a lot more goblet cells that can be moisturizing that air, and a lot more blood vessels in those conchae. So that's what's going on with that. All right? And as I said before, the nasal mucosa is lined with pseudostratified epithelium, okay, with a lot of goblet cells. So here's, you can see over here, air's coming in through the nose. You can see going through the three turbinates over here. This is what the pseudostratified look like. Again, just a reiteration from AMP1. Pseudostratified, basically, it looks like there's a lot of layers here, but each one of these cells is attached to the basement membrane. So it looks like it's stratified. It looks like it's layered, but in actuality, it's all one layer. So we call it pseudo-stratified. And we have goblet cells that are located in between there, scattered. They're going to produce the mucus up there. And also on the tops of the pseudo-stratified epithelium, you have cilia. So as this mucus comes up there, it's going to moisturize the air, but it's also going to collect any bacteria or any dust particles that you might go into your airway, because you don't want that to go down into your lungs. So it's going to collect those dust particles in here, and the cilia are over there to try and sweep up the this mucus with collected dust particles and sweep it go towards back to your nose, so you could sort of run out or cause a sneezing reflex, and you could sneeze it out and so forth. Okay, that's what's going on over here. All right, we have mast cells there. They're going to release histamine. We talked all about that with immunology, so I'm not going to bore you with that. And this is what it kind of looks like. All right, pseudostratified epithelium. As you can see up there, there's a wonderful goblet cell that's up there. Okay. Now, we do have a model of this, so I'm going to spend some time talking about it. All right. So basically this. All right. Most schools have something of this nature. We also have big torsos. You can see this. So let me explain to you about what's going on over here. Here's the nasal cavity. Here's the oral cavity. And back here is the pharynx. And the pharynx is broken down into three parts. We have this blue area that's called the nasopharynx, which is found behind the nasal cavity. Kind of makes sense. All right. We also have the oral pharynx here in green that's behind the oral cavity. And then there's a section that's underneath everything, and that's called the hypopharynx in orange up there. Okay? You can also see the turbinates up there too, the concha. The shells that I kind of drew for you up here are shown here in the nasal cavity. Now you should also know, and everything I'm going to explain to you is in the next few slides too, but you should also know what's found in each one of these pharynxes. In the nasal pharynx, you're going to find the opening to the eustachian tubes that connect to the middle ear section of your ear. Okay? So we have the opening to the eustachian tube right over here. Also, we have one set of tonsils located in this area called the adenoids. They're also referred to as the pharyngeal tonsils, and that's part of the immune system. In the oral pharynx, the green area here, we got two sets of tonsils. We have tonsils that are found on either side of the archway between your mouth and the oral cavity and the oral pharynx, and those are called the palatine tonsils. And I'll show you the size of those. Those are usually the ones that get removed when you hear someone gets their tonsils removed. We also have a set of tonsils over here that's on the back of the tongue, and they're called the lingual tonsils. Again, lingual means tongue. So those two sets of tonsils we found in the oral pharynx. Then in the hypopharynx, the only thing that's really significant there is the epiglottis, which we kind of talked about with the digestive system, that the epiglottis, when it comes down, when you swallow food, it's connected to the tongue, and the way it's situated, it covers, there's two tubes down here, it covers the trachea, but allows the food to go down the esophagus. Okay? So that's what that is. And like I said, because it's attached to your, I think I have a picture of it in another picture. But because I'll show you the picture in a moment. Okay? So the pharynx is broken down into three things. Okay? The nasal pharynx, the oral pharynx, and the hypopharynx. So this is, and everything I just explained to you is in these pictures over here, or the words in here. Okay? That's tonsillitis. So this little baggy thing that you want to, little bunching bag kind of thing, this thing that you see in the back of the throat, that's called a uvula, okay? And it's there to, it's soft, it's connected to your soft palate above your mouth, but it's there to limit big foods from going into your throat itself, okay? So you don't have big foods that your body can't take on, so that's what's doing that. But then you also have these tonsils. These should not be this big. That's tonsillitis. All right, they should be very small, like just covering this area here and over here. But you can see that they are enlarged so much. And the problem is when these get larger and larger, they could actually block the airway, and that's what we're concerned about. All right, little children don't have a large airway as it is, so these things will close up pretty rapidly, and then we'll consider doing a tonsillectomy if we need to. Okay, so that's what that is. So here's the epiglottis. Again, it's a little bit better. I showed it with the digestive system. Here's the epiglottis. We have two tubes over here. Okay? The anterior tube is the trachea that leads to our lungs. The posterior tube is going to be the esophagus that leads to our stomach. Do make sure, hint, we're going to talk about it, that the anterior tube is the trachea. The posterior tube is going to be the esophagus. It's going to become more clear to you why that's so significant. When you swallow food, here's the bolus of food. When you swallow food, your tongue moves to the back, and the tongue is attached to the epiglottis. The epiglottis is then going to, as your tongue moves back, the epiglottis covers the trachea, the top of the trachea. So the food only has one way to go into the back tube, which is going to be the esophagus. And that's how that works. But there is some truth to what Grandma says, don't eat and talk at the same time, because as you talk, that tongue is moving all around, and if so, when you try to swallow, it might not close properly because the tongue is still talking, helping you talk, and the food will then go into the trachea. So there's some truth to that, what Grandma says. Okay? All right, the larynx, which is the voice box. Basically what happens here is the pharynx is going to split into two. You can see those two places. It's either going to go to the larynx, which will lead to the trachea, or it's going to go to the esophagus, and that leads to the stomach. Okay? In the larynx, as you know, above it, they have the epiglottis to make sure that no food goes through there into the trachea. And then we have parts of the trachea that have the upper parts. There's a load of different cartilages over there, and there is a model someplace around here that shows those. I'll show them in the lab. There's something called the thyroid cartilage, and that's what you feel is your Adam's apple, that big bump over there. That's what the Adam's apple is. Okay. The glottis contains the vocal cords, which we'll talk about in a moment. All right. So when you put a mirror down there, if you put a mirror down there, you can see the vocal cords over there. There's the palatine tonsils. These are not inflamed. That's where they would be over there. Okay. The larynx is connects to the hyoid bone. All right, and it's continuous with the trachea to the lungs, and it's innervated by the recurrent laryngeal nerves. So this is your larynx over here, and this is the lining of the larynx. We have two nerves. We have one that's going to come on this side, go down, and then it comes back up and connects here. That's why they call it recurrent. It goes down, but then it comes right back up. Okay? And the same thing over here, it goes up like this. So this is the two nerves that are going to stimulate or innervate the larynx. Now, the problem here is this. If for some reason one of these nerves gets severed, cancer, an infection, something happens, and we, let's say, cut this, then this isn't going to innervate this side of the larynx. So this larynx, see, these nerves over here are keeping your larynx taut, keeping it tight so that we do have an open airway there. But if this one doesn't go on, then what's going to happen here is that this side does not get taut anymore. It kind of goes like this. It's loose. It's relaxed. Now, how is that person going to present? Well, they get very hoarse. As they're talking, air goes through here, and this is just flapping on one side. Does that make sense? All right? If, for some reason, both of them get cut or destroyed for whatever reason, then you're going to have both sides going to do that, but it won't be that you're hoarse, but you can see what's happening. It can actually cause airway obstruction. Now we have an airway that, air is going to be very difficult to get through there because it becomes so narrow. Okay? So that's what's going on here. So these recurrent nerves, which are basically branches off the vagus nerve, on one side gets paralyzed, you will get hoarseness. On two sides, you'll get this airway obstruction. And we need to really fix that, otherwise that person won't breathe properly. Okay? Questions about that? All right. So I'm not going to go through all these. It's more like, there's about 5 different cartilages you should know on here. And just do these on your own. Like I said, there's a model we'll show you when we have lab day where those are. But it's pretty straightforward on that. All right, so vocal folds. We have 2 sets. We have true vocal folds and we got false vocal folds. Now the true vocal folds are, they're the ones that are actually going to produce voice sounds, like the sounds that you're making, okay? Testosterone actually makes them thicker, and when it's thicker, it gives you that deep voice. That's what's happening there. So those are our true vocal folds. The false vocal folds, they don't produce sound. They're there as shells, so nothing can get past that. And I'll show you a picture of what I mean by that. They're also called the vestibular folds. So it prevents any food from entering past the into the lungs themselves. So if you can see here, these are your vocal folds. The white area here are your true vocal folds. So when they're very narrow, you get a high-pitched voice. When they're very wide, you got a low-pitched voice. And it's kind of doing that back and forth. But the vestibular folds, or the false vocal folds, are these areas here. Notice that when this is closed, we have something still over here. So if anything should fall on here, if it falls on these false folds, it'll create a coughing mechanism that you're going to cough that up. You don't want anything to go into that area there in terms of like food, because that just goes right into the lungs themselves. So if we didn't have the false folds there, then we have an opening there and an opening there. So they're just there to protect things from entering down below you further. Okay? And they're very sensitive over here, so if anything touches there, you get that cough reflex. Okay? So again, you have the vocal folds, really thin versus, and you can, singers can actually do this, it's controlled by all these muscles here, but they can control this to create different musical sounds that they do. Okay? So closed during coughing, sneezing, and I'm going to talk about Valsalva maneuver in a little bit, what that actually is. Okay? So these are closed during those times. Well, I might as well talk to you a little bit about Valsalva maneuver here. All right, Valsalva maneuver, something you do all the time. Okay? Basically what you're doing is you're trying to exhale against a closed glottis. Now think about when you would do this. You're exhaling, but no air is coming out because you're closing your glottis, right? Your epiglottis is closed over there, so you can't let it out. So it's basically every time when you move a bowel, you're doing that. If you think about it, what you're doing is you know what I'm saying? You got that Patrick Swayze kind of look. I don't know if I should use him anymore. Steven Seagal. You do that. What you're doing is that you're trying to exhale against a closed glottis. So the air can't go out, so it stays within your chest. And the only other place it can go out is the back end. Because what happens here, and this is where you got to think physiology, the pressure inside your thoracic cavity increases because you can't let that air out. So it increases here. It finds another escape. It passes it down the pressure to the abdominal cavity. Does that make sense? And then from your abdominal cavity, things will be pressed on your intestines to try and push out the stool. And that's what happens there. Okay? So you do this quite often, a Valsalva maneuver. Okay? If I'm trying to lift up this table, I'm going to do a Valsalva maneuver. Right? I don't want to let air come out. Try and do this when you're, not this. Well, next time you're sitting on the bowl, all right? I can talk about this because it's anatomy and physiology. Next time you're sitting on the bowl and you're having a bowel movement, try. It's not going to hurt you. Try and do it with your mouth open. You can't do it because you can't create that pressure to push out your stool. I know it's funny and all, but it's the truth. It's called a Valsalva maneuver. All right? Same thing about lifting up. I was trying to say, when you lift up things, it's better you can get some leverage if you can actually cause yourself to have a Valsalva maneuver. You're actually doing this and you can actually get more leverage. Try and lift up something with air coming out of your mouth. It's going to be difficult, right? And all you women who have had babies or going to have babies, it's important to, as I try to train the mothers into pushing and stuff, it's important that when you're trying to push the baby, all the pressure is down below. It's not up here. So when a woman's trying to, I can't push, I can't, that's okay. Then we'll just, next contraction, we're going to let you relax a little bit so that you can catch your breath and stuff. I understand, but it's a lot of work. That's why it's called labor. So you're pushing the baby out. You want to hold your breath and push. So you don't want to have any air come out here. You want your pressure from the thoracic cavity go to your abdominal cavity, to your pelvic cavity, to push the baby out. That's what's happening with that. So you guys do Valsalva maneuvers all the time, okay? And that's what's going on with that, okay? So it helps to empty the rectum, acts as a splint to stabilize the trunk when lifting heavy objects. You do this all the time. We're going to talk more about this when we get into physiology too, and what that actually does to the thoracic pressure. What does it actually do to blood pressure and things like that? So we're going to get back to the Valsalva maneuver. So hint, do understand the Valsalva maneuver. I guarantee there'll be a question or two on the test. All right, now the trachea, all right? It's a windpipe, and what it is when you see the trachea, it's shaped like this, and we have these rings, 16 and 20 rings that are going to be located here. We got a ring here, a ring here, a ring here, a ring here, and let's not draw on the scale, but there's about 16 to 20 rings going around here. Now, why do we, and the rings are made of hyaline cartilage. Why do we need to have rings around the trachea? Remember, the trachea goes up and down like this, and then it splits into two lungs. Why do you need to have these cartilaginous rings around the trachea? What's the purpose of it? As opposed to not having it in there. We just want to have just soft tissue there instead. Well, when we have soft tissue, here I'll tell you, when you have soft tissue, it might have a tendency to collapse on itself. Right, it holds it, so the rings here are holding it stiff. It's kind of like having a fire hose compared to your vacuum cleaner hose. Right, your vacuum cleaner hose can stand up by itself if you wanted to, because it has those ribs in it, right? But a fire hose, it'll just collapse. Not a good thing when you want air to go through there. So we got to have rings. Now, the thing is, these rings, if I take a cross section of this and blown out over here, the way it's going to look is this is what the ring looks like. So this is your ring. This is the anterior view, and this is the posterior view. But it's shaped like a C shape or a U shape. Why is it not an O shape? Why is it not shaped like this? Remember, this is cartilage, hyaline cartilage, hard. Why is it not shaped like that? Why is it shaped like this? What's the rationale here?
To allow it to expand.
It won't expand. It's hard stuff. What's located here?
Your esophagus.
The esophagus. The esophagus is over here. And the esophagus is going to have food. You see what I'm trying to draw here, right? When this esophagus, and this could expand, when this esophagus gets filled with food, it's going to have to expand and go into this area here. See that? So you don't want a full ring there. You've got a problem swallowing your food. So that's why it's shaped like this. All right? Yeah, there's a little ligament over here, nothing, but it's a soft ligament. So it can be pressed down. So this is where physiology reflects anatomy, or function reflects structure. It makes sense why that's shaped like that. Okay? So that's what's going on here. All right? Gives support. Posterior, there's no cartilage, and it's because the esophagus is found in the posterior aspect. When you look at microscope slides, you'll see that also. Okay? So 3 layers. There's a mucosa, submucosa, and adventitia. Pretty straightforward. The lining of the trachea is going to be pseudostratified epithelium also. Okay? Cilia in there. There's going to be mucus in there to collect any dust particles so you can cough it out. Okay, if you need to. So this is just showing you what I just drew for you. All right, here's a schematic view of this blue area is the hyaline cartilage ring. The yellow here is going to be connective tissue, but you also see the lining of the lumen of the trachea is epithelium. That will be your pseudostratified epithelium. This, in the posterior aspect, is going to be your esophagus. Now you look over here. Here's the esophagus. The yellow area here is going to be the hyaline cartilage. Remember, it's a C-shaped ring, and it makes sense why it's C-shaped. Okay? And I have a microscope slide showing this too. Here's the microscope slide. There's the lumen of the trachea. This is the epithelium lining. That's going to be pseudostratified epithelium. You can recognize that. All right? It's all connective tissue in here. And here is the hyaline cartilage, right? That looks like hyaline cartilage. And it sure as heck is. Okay? You can see the lacuna there and whatnot. All right? Good old stuff. All right? All right, now, listen to what's going to happen here. The trachea comes down, and then it's going to split into two. All right? So here's your ring cartilage over here. And here's the two bronchi. Now, here's a little question for you. If someone, a child, swallows a peanut, and for some reason it goes down the trachea, all right, laughing and giggling, and it goes down the wrong pipe. When it goes down the trachea, does it tend to want to go down to the right lung or the left lung? Or is it really just a 50-50 chance?
Right on.
Right lung. Why? No idea. There's a guess, right? Let me explain to you why. It is the right lung. What happens here, and this is what's in your book, but people just tend to read right by it. They'll just say that the right bronchus is more continuous with the trachea. And people are just like, well, what's the big deal? Let's go on to the next statement. Let me explain to you significance here. This is what I mean by more continuous. Here's the trachea, and the trachea kind of goes like that. It just bends a little bit that way. That's the right bronchus. The left bronchus kind of grows outwards like this. So as the peanut, whatever you want to do, as this peanut comes down here, it's going to go with a trajectory of where that's going. Does that make sense? This is more steep than this. Can it go into the left lung? It can, but it's going to have to do this weird kind of left-right angle to get in there. So if you know that someone swallowed a peanut and went into the wrong lung, and you don't see it, you better be concentrating more on this side, on the right side, because that's where most of the cases that pill is going to go, where that peanut's going to go. Okay? Also, just want to say, this area here, where it splits, that's called the carina. That's all it means. Okay? So the right bronchus, as I just explained to you, there's less of an angle over there. It's more steep. Okay? And the carina is just where the two are splitting. Okay? So cartilage. Now, at this point here, the rings on the bronchi are completely round. Why? They're not C-shaped. They're O-shaped. Why? They're esophagus. Okay? That's what I'm trying to show you guys is don't just memorize. Understand the concept. There's complete O's over here because of what's not found behind it, right? So I think it goes a long way. If you understand why it's doing that, then there'll be less memory for you guys to do. All right? All right, then what will happen is these bronchi start turning into smaller tubes. So these bronchi go into what we call bronchioles. And these are primary bronchioles. They'll go into thinner things. They'll go into secondary bronchioles, tertiary bronchioles, until it gets very, very small. It keeps on going that way. All right? As we do that, the lumen gets narrower and narrower. All right? They don't contain any cartilage or goblet cells because you want to get really thin down there. And what we got here is basically an upside-down tree, right? There's your trunk, splits into two main branches, and then you got smaller branches, smaller branches, smaller branches, until you got the leaves, which are really the air sacs or the alveoli. So just think of the lungs as an upside-down tree, and a lot of times we refer to it as a tree also. All right? So we call it the bronchi plus the lungs. We'd say the tracheobronchial tree. We usually refer to it as the tree because it looks like an upside-down tree. Okay? Now, let's look at the alveolus. or the many of the alveoli. So the bronchioles will lead to alveolar ducts, which lead to the leaves of the tree, which are the alveoli, right, the air sacs. This is where we're going to increase our surface area astronomically, okay? Where we're going to have many, many of these air sacs or alveoli on the tips of these bronchioles. Along with that, with the air sacs, we're going to have tons and tons of capillaries. Because again, this is where gas exchange is going to happen. So as soon as oxygen comes off the air sacs, they want to go to the capillaries, to the lungs, capillaries, where the red blood cells are, so you can put it onto the hemoglobin. So we're going to have tons and tons of capillaries on here, all right? And we got to increase the surface area astronomically so that we can have much more gas exchange occurring, because we're beings that need oxygen, okay? So the place of our gas exchange where oxygen goes off the lungs onto the red blood cell, carbon dioxide needs to come off the red blood cell or the blood itself and go into the lungs. And it's also going to secrete something called surfactant. Surfactant is going to decrease surface tension. Now this is where you got to understand the difference. The word surface, a lot of time, when I say surface tension or surface area, most students just hear the word surface and they think it's the same thing. They really have nothing to do with each other. You got to be paying attention to the multiple choice questions, right? Surface area, as you know, it's going to increase the area at which things could actually touch, with gas exchange, things like that. Surface tension is basically something that's going to, basically something wants to get smaller. The tension, the surface wants to get smaller. For instance, you have two bubbles. You could have a small bubble and you could have a big bubble. What's the chances of the small bubble popping compared to a big bubble? The small one is going to, well, is it going to pop more easier, or is it going to pop harder? Harder, right? I mean, you know the concept of surface tension. The smaller the bubble is, the surface tension is much higher. And it's going to put in, you have to put in extra effort to blow it up. Does that make sense? Okay? You want to make sure that the surface tension in your alveoli, which are these little bubbles, are not going to be so small. They want to be able, you don't want them to collapse. You want it to be able to expand to get more air into there. So what surfactant does, surfactant gets released by certain cells in your lungs, and it's going to try and keep the surface tension down so that it can expand so that more air can get in there. Does that make sense? All right? So surface tension, surface area, two totally different things. Don't get mixed up between the two, though. Okay?
What is the surface area?
Surface area is the area of which something could actually touch, or something that could actually have an exchange on. For instance, surface area for this, the only place that things can touch is on the area where you can do this. But we can increase the surface area by breaking this. We created two new surface areas that we can touch at. We can break it here and create new surface area. So every time we do that, we're creating new surface area. If we just have, let's say, we've done this with emulsification, right, when we got a fat droplet. If you have a fat droplet like this, the only place things can actually touch, lipase can actually go on, is over here. But if we actually take this and break it up into two parts, the same lipase can go over here, but we've created new areas where lipase can actually touch. We've increased the surface area because now lipase can hit these areas over here also. Does that make sense? We're increasing surface area without changing the volume of the creature that we started off with. I'm sorry, the what? Microvilli. Yep, the microvilli. We're increasing surface area that way too when we dealt with the small intestines. All right, so just don't get mixed up with surface area and surface tension. They may relate to each other, but they're two totally separate entities. Okay? So that's what's going on. And surfactant is a chemical that keeps the lungs from collapsing, for keeping the lungs from not having strong surface tension. It decreases the surface tension. And this is what it kind of looks like. Again, there's a terminal bronchiole leading to the bronchioles over here, to the alveolar ducts, and then you have all these alveoli at the ends of these branches, so to say. Okay? By this time, when we get to the alveoli epithelium is very, very, very thin. In fact, we call it simple squamous epithelium. Okay? It's one layer thick, it's very thin. This allows for an efficient amount of gas exchange to happen. You don't want to have big cells, thick cells there, because now the oxygen has to go through all of that to get to your blood vessel, and then the carbon dioxide has to go through all of this to get into the air so you can breathe it out. But if you can have this cell thin, now it just has to go through that and comes right out, goes through here, very thin. So we expect that lung tissue, epithelial tissue, is simple squamous epithelium. Okay? So you can see the respiratory bronchiole over here, and you can also see little alveoli all around here, little balls and stuff. We're going to show you that with a microscope much closer. But that's a key thing to understand diseases, pneumonia and stuff, and emphysema that we're going to talk about. Okay? So again, we're going to have the capillaries all around the alveoli, okay, which we expect to do that so that we have more gas exchange to occur. Okay? So we have this alveolar capillary walls between the two of them so that we can have this fusion going on. Now, the type 1 pneumocytes are really just the cells of the simple squamous epithelium. They just have a special name if they're actually in the lungs. We call them type 1 pneumocytes. Type 1 pneumocytes is that single layer. It's a simple squamous epithelium. Each one of those cells is called a pneumocyte type 1. They're also the ones responsible for secreting ACE, angiotensin converting enzyme. We talked a little bit about that when we dealt with blood pressure and what that does. It converts angiotensin 1 to become angiotensin 2. If you remember, angiotensin 2 is the activated form of this angiotensin, and it's going to target the adrenal cortex to release aldosterone. If you remember what aldosterone does, it reabsorbs sodium, water's going to follow, and that's going to increase blood volume, which will lead to an increase in blood pressure. Okay? We do have ACE inhibitor medications that will block the type 1 pneumocytes to release ACE. If that blocks it, you're not going to have an increase in blood pressure. So ACE inhibitor medications are used for an antihypertensive condition, or we're going to decrease the high blood pressure in someone. Okay? And then we have type 2 pneumocytes, and these are the ones responsible for secreting the surfactant to decrease the surface tension so that the lungs don't stay collapsed. There's a possibility that we could actually expand it. Okay? Surrounded by, or the alveoli are surrounded by many, many elastic fibers so that it can collapse. When you breathe, and we're going to talk about this later, another day, but when you breathe, you inhale, you got to think about the inhalation, but when you exhale, you don't have to think about it. It just happens automatically. Why does it just let out all the air? Because it has a lot of elastic fibers. When you take a rubber band and you stretch it, when you let go of it, it naturally wants to recoil. It's the same way as your lungs. It naturally wants to collapse so that you could actually expel all that air. Okay? So we have a lot of elastic fibers all around our lungs to create this recoiling action so you could exhale all this air that's coming out. Okay? And it has these pores, which we'll talk about later. And then dust cells. Ooh, right? Remember we talked about Kupffer cells? They're macrophages in the lungs. I'm sorry, Kupffer cells are macrophages in the liver. We have microglia cells that are macrophages in the brain. And now we have dust cells that are macrophages in the lungs. They're just the same thing that we talked about with immunology. They're just found in the lungs. So you can see on here, this is many alveoli on here. The yellow here is trying to show you the tons of elastic fibers that help collapse those lungs. And then we also have the capillaries that are there, tons of it, so that we have the gas exchange. Now, yes, I've been saying the words, want the lungs to collapse. You want it to collapse, you don't want it to stay collapsed. And surfactant is going to prevent your lungs from staying collapsed. You want them to collapse, but you want it to also be able to spring open again with a lot of air. This is an alveolus over here, and you can see they're trying to show you these are type 2 pneumocytes, these green things. Those are the ones that are going to produce and secrete surfactant. You also have each one of these cells in here is a type 1 alveolus, type 1 pneumocyte, and those are going to secrete ACE, but those are our simple squamous epithelium. Okay? And you can also see the many capillaries that are going around here, and also these blue things are your macrophages, your dust cells. But you can see where we have the gas exchange going on. Okay? So just as a recap, just to show you, we have one trachea over here, which there's only one. There's a lot of cilia there. There's smooth muscle on there, and there's also cartilage. But as we get smaller and smaller and smaller, our numbers are going to increase when we get to alveolar sacs, and by this time, we only want one layer there. We only want simple squamous epithelium. The more layers you have, it's going to be more difficult to create a gas exchange, because that's to go through all those layers. So by the time it gets to the alveoli, tons of stuff, the surface area is astronomical, but there's no cilia, there's no smooth muscle, and there's no cartilage. It's only that one layer. So we start losing that as it goes down to the bottom of our upside down tree. Okay? And then really quick about this, medical procedures, auscultation, that's what the doctor and nurse is doing. You're taking the stethoscope and you're listening to the lungs in and out. Cardiopulmonary resuscitation, you know what that is with CPR. Okay? Breath sounds, this is kind of a fun thing. You listen to the lungs, doctor will either say, clear to auscultation, CTA, meaning like you could hear the lungs, you could see the air, you could hear the lungs filling up with air and emptying with air. You can hear that. So this is normally what you hear. But then other things that they'll be not wanting to hear, but other things that they might hear is things like rails and crackles. Okay? These things here, we could have wet rails, or dry rails. The thing is, when there's a wet rail, and the best way that what this sounds like, if you take your hair, and it's right by your ear, if you take your hair and rub your hair together, that's what a crackle sounds like. It's that crackling kind of sound. Not up here, not over here, but when you listen to it in the lungs, you'll hear this rustling, this crackling over here. And you'll be able to tell the difference between wet and dry when you listen to more of these as you get into your fields. But a wet one, obstruction of alveoli, usually pneumonia is affecting there, and dry is something we're going to get into called fibrosis. Okay? So that's what you're hearing if you hear something like that. Those are bronchi, and bronchi is like this snoring kind of sound, like a but not up here, down here. And it's usually some kind of swelling or buildup of mucus in there. People with cystic fibrosis, we hear a lot of this in the lungs. Okay? We also hear stridor. That's a sound you do not want to hear. Stridor is telling you that something above in the upper respiratory tract is blocking it, like the epiglottis. We have something called croup. Even I know you guys heard of croup is a certain kind of infection. It's when the epiglottis gets so thick that it's covering the trachea virtually all the time. Not something you want to happen. And when they cough, it has like a seal barking cough. That's what it sounds like. So that's a sound that you don't want to hear at 3 o'clock in the morning of your child. That's going to get you up to bring the child to the hospital instead of waiting to 7 o'clock in the morning when it could be too late. So that's what I mean by hearing the sounds. Then you could also have a sound where it's going to be, let's say, the passageway someplace in here is narrow, like in asthma, which we'll talk about. When it's narrow, now the air is going to a narrow passageway, and it's creating this whistling sound, this wheezing sound. And it usually happens as an exhalation kind of sound. Now, you can hear that definitely in the lungs in someone who's got asthma. But if it's so severe, you could actually hear it out of the mouth too. This sound. I'm making it louder so you can hear it on here. But that's what that is. So it's kind of where the sound is passing through a narrow passageway. Okay? And a pleural friction rub, we'll learn about pleuritis later on, but basically this is where the lung is actually touching the lining of the lung and the lining of the thoracic cavity, which is called the pleura. When they get thickened, they're rubbing against each other. And what it sounds like is you stepping in snow. Like, you know what it sounds like. This is something I can't really say if I was teaching in Hawaii. But I think you guys understand. Stepping in snow, that's what it kind of sounds like. But again, it's down here, and usually some kind of pleurisy or pleuritis. And that's what's going on with that. Now let's talk about the lungs themselves. Okay? They're spongy, air-filled areas. They're highly vascular. We talked about those little, quote-unquote, leaves or those air sacs. Many, many air sacs are called alveoli, or one alveolus. And all around those air sacs, as alveoli, are going to be highly vascular capillaries. Because this is where you want to have gas exchange to happen. All the air is going down to the alveoli, and now it's going to go into the blood vessels to fill up the blood with oxygen. And all these carbon dioxide, the waste product of making ATP, needs to be blown off. So it has to be transferred from the blood onto the air sacs so you can blow it off, i.e. gas exchange. Okay? And we basically have, when you draw this, this lung setup, kind of like this, right? Your heart would sit in there. Down here is what we refer to as the base of the lungs. And over here, where it kind of is pointing, we refer to as the apex. The high lung is the area that's going to be most medial, basically where the heart sits and where the bronchi actually go into the lungs and where the pulmonary veins and arteries connect to the heart. Okay? And then if you look at the left lung, if you take that out, and I think there's some models of this, you'll see that there's a little notch here, basically where the heart sits. We call it the cardiac notch. That's all that is. Okay? All right, so the right lung. The right lung, we actually have 3 lobes over here, and in the left lung, there's only 2 lobes. So the right lung kind of goes like this and like this. And we have 2 fissures. Basically, in the right lobe, we have 1, 2, 3 lobes, the upper, middle, and lower lobe, or they also refer to it as a superior, middle, and inferior lobe. All that's fine, okay? And then we have 2 fissures, basically 2 lines to divide it. One is going to be sort of parallel to the floor. We call it the horizontal fissure. And then one that's on an angle, we call that the oblique fissure. So that's what that is. On the left side, it's smaller. There's only 2 lobes over there. And it's mainly because the heart has pushed it. Since the heart is centered in the chest, but it leans to the left. So because of that, it pushes the left lung a little bit, creating that notch. Because of that, there's only going to be 1 fissure there, and that's going to be on an angle, so we call it the oblique fissure. There's an upper and lower lobe of the lung, or they refer to as the superior or inferior lobe of the lung. Okay? There is, and I'll show you over here, there is a remnant of the middle lobe, which kind of goes like this. Well, you'll see it on the picture. We call this remnant the lingual lobe because it kind of looks like a tongue. So I'll show you what that is. Okay? So here you got the, well, I kind of drew it backwards, but you can see it over here better. So here's this is the right side, so you're looking at the anterior view. Here's the superior, middle, and inferior lobes of the right lung. You have the superior lobe, and here's the inferior lobe of the left lung. But you'll see there's this remnant of the middle lobe we refer to as the lingual lobe. It's really just, when you look at the left lung, it's just an extension of the superior lobe. Okay? This is what it looks like in the anterior view. This is what it looks like on the lateral view. Kind of different. When you're going in, especially into respiratory therapy, you should know where all these lobes are in reference to what part of the body that you're going to be listening to. Should you be listening to pneumonia, something called consolidation. If you think it's in the superior lobe of the right lung, you should be hearing it here, but on the lateral side, it's going to be shaped like this. When you look at on the inferior side, notice that the inferior, now this is the right side and this is the left side. You look at the back side, the posterior view of the lungs, you're seeing that you can see this huge inferior lobe because it's going to predominate the posterior side of the right lung. This is the way that they're all shaped. You can't even see or even hear the middle lobe of the right lung. Okay, so you got to think in three-dimensionally. Then we have these three lobes: superior, inferior, and middle on the right side, and the upper or the superior and inferior on the other side. But we can also break down each one of those lobes also. Now, I'm not going to ask you this, but this is something, if you're especially going through respiratory therapy, yes, that you could actually say, here's a superior lobe, but this is the apical portion of it, the anterior portion of it, the posterior portion. If there's a cancerous tumor that's over there, they need to say, well, where is it in the superior lobe? And to be more precise, you can start designating what part of the superior lobe that each part has. There's like subtypes, all right? And then you have bronchioles that go to each one of those areas. All right? Again, I won't ask you that, but I want you to appreciate that it goes it subdivides even further, and that'll be your bread and butter if you're going to respiratory therapy. Okay? Now let's just talk about chest X-rays very briefly. Chest X-rays, the way that the chest X-ray goes is the X-ray is going to go through the body until it reaches the film. Right? The film's not inside you. It's going to be someplace against your body. So this is important, especially for radiology people. So you could do two different ways. You could have the rays, where the camera is. The rays are going to go through the body, and the film is back here. Or I can make the rays go this way, and the film is in the front. That makes a big difference, okay, depending on what you want to look at. Now, there's something called the posterior-anterior chest X-ray. We call it the PA view. And what that's saying is the trajectory of the rays that are going. If it's going if it's going from the posterior view or posterior side to the anterior, we call that a PA view. So the film is actually on the anterior side. Now, and I'm sure most of you, if not all of you, have taken a chest X-ray. You might or not remember this, but when they asked you to get the picture done, the X-ray done, they told you to put your body as close as you could to the wall. Probably remember that. Okay, the wall is where the film is. If you're far away from the wall, even if it's like a few inches to a foot, then what's going to happen is the rays are going to spread out, and it's going to make the picture, when they show it on the film, much bigger than what it is. So it's not going to be that that precise. The best thing to do is get that lung as close as you could to the film. So they ask you to put your body right against the film, so that it's not going to be, it's not going to obscure the view, all right? The best view for the chest is a PA view. That you're going to need to know, okay? You need to know the PA view because that gives you the most precise, okay? That's where the film is on the chest. This is the most commonly requested view, okay? We also have the AP chest X-ray. The AP chest X-ray is that you're going to go from, the rays are going to go anteriorly, posterior. So the film is going to be in the back, okay? But the lungs are closest if we take it in, if the film is in the front. Does that make sense? The lungs are closest to the anterior view. When you get it back here, it has to go through muscle and thick skin. It gets obscured that way also. So we rarely use an AP view. However, when would you use an AP view in the hospital? If you want to look at the lungs. When would you want to put the film in the back of the person, which isn't the best thing? In the bedroom. This is exact. When a portable chest X-ray or a portable X-ray needs to come to the bedroom of the patient, a patient's room. In other words, if they're intensive care and they have all tubes all over them, it's going to be very difficult to bring that whole bed with all the tubes all the way downstairs and bring them to the X-ray machine. It's easier to bring the X-ray machine to them. Does that make sense? And that gets done quite often. It's not the best view. It's basically the only view you can really get if you need something, okay? But it's going to be a little bit obscured. You can't put the film up here and put the X-ray from underneath the bed. You're going to get the box spring and all that stuff. So you've got to be able to put the film over here and the rays go this way. So they do it, but they're not the best. It's the last resort. And then you could also do a lateral view, which is, they'll tell you to put your arm like this against the, and you want to get a lateral view of the lungs. You could do that also, but you're only going to see like one part of it. Now, here's where my clinical aspect comes in for you. When you suspect some kind of disease, someone's coughing up blood, and we know it's not heart-related. We need to make sure, it could be, let's say, pulmonary hypertension, but we know it's not heart-related. We're trying to rule out if there's any cancer in the lung. What they're going to do is that they'll do a PA view of the person's lung, and lo and behold, you're going to see something called a coin lesion over here, an area of some sort of lesion. There's something that's not supposed to be there. Some kind of consolidation, some kind of solid thing, a tumor. Okay? Now, we definitely see something there. Is it cancer? It's highly suspicious of cancer until we take a biopsy. But we get a better view if we take a picture of it, or to get a better three-dimensional view, we need to take 2 pictures of it. And I'll show you why. Later on, you'll get to learn all about cancers and different stages of them. And I'm just going to give you just a quick number kind of thing. It doesn't follow anything, but the idea is what I want you to understand. For going from stage 1 cancer to stage 2 cancer, and let's say of the lung, and it's different for each organ. Stage 1 cancer of the lung might be anything up until 2 centimeters in diameter, or let's say 2 centimeters large mass. If it's larger than 2 centimeters, then it's going to be stage 2. Now the stages actually tell you what's the form of treatment you're supposed to do. Because studies say, hey, look, you could actually survive 5 years if, and I'm just giving you examples, I don't know if this is true or not, but just the idea. But if it's stage 1, we're going to give chemotherapy because there's an 80% success rate. 5 years later, it's a survival rate. In other words, you do chemotherapy at stage 1 of this particular, let's say, lung cancer, then there's a 80% chance that he'll be living still at 5 years. If we did radiology, or let's say radiotherapy, shoot in like rays over there, at stage 1, it's a 60% chance that he'll survive in 5 years. So they go by studies. So knowing if it's stage 1, stage 2, stage 3, stage 4, that's going to help with that patient's prognosis. Does that make sense? Okay? Now, this here, we do this measurement over here. We find this, and we say that it is 1.5 centimeters. Hey, following that rule, it's under 2 centimeters. He's in stage 1. But you need to do a lateral view, a side view. So here's where you're looking at this way. Here's the person's chest, breasts are over here. See how I'm looking at it? Here's posterior, here's anterior. So you're looking at the lateral view, and that 1.5 centimeter is right there. But when you look at this view, it goes back like this, and now this is 4 centimeters. Do you see how it changes? He's not stage 1. From this view, it shows that it's stage 1. But we look at the side view, the lateral view, he's really stage 2. So if you suspect a disease in the lungs, you've got to do 2 views to really understand the 3-dimensional aspect of here. If you don't suspect a disease, then you're just going to do a routine PA. In other words, you're going for a C-section to deliver your baby. They want to do, the hospital requires that there's a baseline of a chest x-ray. You seem healthy. We just want to get a baseline. Should everything happen later on, we just want to have a baseline, what your chest looks like at this point. So we don't suspect any disease over there, so we're just going to do a PA. Does that make sense? Hint, hint, it will be asked. Okay? Does that make sense to everybody? Okay? And I wrote, and this is basically what a PA looks like, and here's a lateral view. Okay? And what I just explained to you, if routine chest x-ray, you just want a PA view. But if you suspect some sort of disease, you got to get two views, usually a PA and a lateral. Is that clear about that? Okay? Okay. I kind of put that in there, especially for people, because usually about a third of the class is going for radiography. You need to know these things. Okay? All right, blood supply to the lungs. All right, it's perfused by two different circulations. All right, the pulmonary system, which we've already killed before. All right, you got your pulmonary arteries and pulmonary veins going over there, and blood goes through there to get the gas exchange to occur. But the tissue itself of the lungs needs also perfusion. Does that make sense? As much as the heart muscle needs, let's say the heart holds blood, but the heart muscle is tissue. It needs oxygen and nutrients and all. Like that, we also have the lungs. That's tissue, and it needs oxygen, it needs nutrients as for itself. So we have the bronchial arteries and bronchial veins that do that, okay? And they come off of the thoracic aorta, all right? The bronchial, this is kind of an odd thing. The bronchial veins that carry deoxygenated blood from the lung tissue, they anastomose with the pulmonary vein. The pulmonary vein carries oxygenated or deoxygenated blood? Oxygenated. So you're getting some of the bronchial veins carrying deoxygenated blood, and they're going to dump it into the pulmonary vein, which is carrying oxygenated blood. Does that make sense? Right? That means, yes, some deoxygenated blood will mix into the left atrium. Okay? You got to go back to the old stuff, right? You got to always build on this stuff here. Okay? But go back to that, and you'll understand what that's all about. Okay? Thoracic cavity. I'm going to do this pretty rapidly for you because you kind of did this in A&P 1. The thorax, bony cage, all right, has the sternum in the front, the rib cage around the sides, and then you've got the vertebral column in the back, and it protects the thoracic cavity. The mediastinum is the area that's found between the lungs and the trachea. So it's where the heart is sitting. But there's other stuff in there too. All right? So there's your rib cage. If we remove the rib cage, we've got this. This is the mediastinal area, or the mediastinum. In the mediastinum, yes, the heart's there, but there's other items that are also there also. So don't get that mixed up, right? Don't think it's just the heart. You have also the phrenic nerves that come down, which we'll talk about later, right? You have the aorta that's going to be a part of that. You also have the pulmonary arteries and veins that are going to be a part of that mediastinal area. If you remove the heart, you can also see all this other stuff in the mediastinal area, right? You're going to have the esophagus will be found there, the aorta, and all those other ones I was telling you about. So where does that come in? Well, if they have to do an x-ray, if the doctor feels as though that there's some sort of mass that's coming from the mediastinum, they've got to figure out where that's coming from. All right? So it could be coming from any of those areas over there. All right? So that's what you'll be doing. You'll take a picture of the chest, and they'll look into that.
So is it like basically everything except the lungs?
Correct. That's basically what it is. Yeah, because the lungs are filling up the rest of it. But it's that middle part, basically, where the between the two lungs. But it's not just the heart. All right? Understanding it's just the heart, that's kindergarten. Your anatomy and physiology, you know there's a lot of other structures that are located in there. Right? Okay. The diaphragm covers the inferior portion of the thoracic cavity. Okay? And it's controlled by the phrenic nerve. We learned about the inferior phrenic arteries. They give blood supply to the diaphragm. The word phrenic means diaphragm. So we have two nerves over there. And they should be going, the innervation should go, both the two phrenic nerves go down to the diaphragm at the same time. So it should fire the diaphragm and contract it and be able to do this kind of motion. Now, if they fire not in sync, that one fires and then this one fires, then the diaphragm will actually go like this. Does that happen? That's a hiccup. 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 That's what's happening with that, is that they're firing. It'll take some time, as you know, it'll take some time, a few minutes, for it to get back in sync. Why that happens, we're not too sure. But that's basically what a hiccup is when the phrenic nerves are not firing at the same time in sync. Okay? Now, the diaphragm, a lot of people think, when the diaphragm contracts, question? It's any time. It's not just eating. We don't know exactly what causes it. It could just be, right now I get the hiccups. Or when they're laughing. Laughing kind of makes a little bit more sense because as you're laughing, that there's going to be a lot of motion with that diaphragm. And perhaps because there's so much motion with the diaphragm when you're laughing, that it goes out of sync. So it takes some time to do. So we usually see that with laughing. But it could just happen like right now. You just get the hiccups. We don't know exactly what would cause that. Okay? Other questions? Okay. So when we have the diaphragm, this is our chest wall, and here's our diaphragm over here. Now, when the diaphragm contracts, most students get mixed up with this thing. But when the diaphragm contracts, does that make the thoracic cavity smaller or bigger? In other words, when the diaphragm contracts, does the floor of the thoracic cavity move down or does it move up? It goes down. What happens here is that when this diaphragm contracts, the way it works is that it actually will move this way and pull down. So the thoracic cavity moves down. I'm going to exaggerate a little so you can see it. But it moves down when it contracts. When the diaphragm contracts, does that make the thoracic cavity bigger or smaller? Bigger. It's going to make it bigger, which means it's going to allow for inhalation or exhalation? Inhalation. So that's how diaphragm, when that contracts, it allows you to inhale. Okay? Now, we also have muscles that are located in between the ribs. They're called intercostal muscles. Costals mean ribs. So they're found in between the ribs. Now, when these contract, they bring the ribs closer together. So if they bring the ribs closer together, is that going to make the thoracic cavity smaller or bigger? Smaller. So the intercostal muscles is going to aid with exhalation, to blow out the air. Now, here's a little caveat with this. The intercostal muscles are usually never used. The reason why is because, as I explained to you before, there's so much elastic fibers all around the alveoli that it just naturally will just compress. You take a rubber band, here we go. You take a rubber band and you stretch it. When you let go of it, it naturally wants to get smaller. Does that make sense? There's tons of these, if you want to visualize, let's say, elastic bands around the alveoli. There's tons of the elastic fibers all around your alveoli. So when it fills up with air, you've got to do this with the diaphragm. There's some effort here. When you want to inhale, you're going to take a deep breath, you've got to forcefully do that. As much as you've got to forcefully put air into a balloon. But when you want to let the balloon let out all the air, it does it naturally. It's more of a passive movement. Does that make sense? Okay, it does it automatically, so to say. The only time now I could use my intercostal muscles, but I would do that once I get, like here, I'll take a deep breath, diaphragm goes down, I'm going to exhale, but if I want to exhale all of it, now I'm using the intercostal muscles. I don't need to use them. Does that make sense? Because most of it has already come out. All right? People with emphysema, which we're going to talk about, they use it because they have problems with the elasticity of their lungs. Okay? So that's why I said the intercostal muscles, it only aids minimally to exhale. It's more of a passive movement. It normally wants to just exhale by itself. So those are intercostal muscles. Okay? All right. Now, the pleura, the covering around the lungs is called the pleura. Okay? The thoracic cavity is also referred to as the pleural cavity. Okay? It's double layered, something you learned from chapter 1 in A&P1 where we're going to deal with visceral and parietal layers. Okay? So it's very similar to what we talked about with even the pericardial sac that we talked about a few weeks ago. So we have the visceral layer, or the visceral pleura, that's actually on the organ itself, right, on the lungs. And then you have the parietal layer that's going to be on the thoracic cavity, the wall of the cavity itself. So you have, and then you have this area in between. We call it a potential space. Now, the visceral and parietal layers are touching each other, but they can separate if you put something else in there. Now, think of your putting your hand, I think I have the next one over. Yeah. Remember this picture, right? This is where you're going to put your fist in a balloon. The layer that's on the fist is the visceral layer. The layer that's going to be around here is going to be the parietal layer. And then it's separated by, and technically speaking, these are really, in real life, they're touching each other. They're just having a space there exaggerated so you can see the picture. But there's space here. Now, if that's touching each other, the visceral and parietal layers, if you want to open up your hand or expand your lung, it's not going to be able to do that because you've got friction going on, right? The visceral and parietal layers will be touching. You can't expand it. But if you put a few drops of water in here, now it's able to slide and glide over each other, allowing it to expand and contract. So we have to have, and that's where I want to go back here, you have to have a little bit of pleural fluid that will actually decrease the friction between the two membranes, the two pleura, okay? To allow it so it expands or not. Okay? That's where we did the pericardial sac. Similar, you'll see in the reproductive system, you saw the digestive system, you have the visceral and parietal layers all over the place. All right? But again, this is exaggerated. They should be touching each other. It's just a very minimal amount of fluid in there. Because if you have too much in there, then it's going to be pressing against the lung, and the lung can't really expand to full capacity. So it's only very little that's in there. So it's this potential space. But things can get in there and cause problems. Okay? That's why we call it, it has a potential space. It's not there, but a potential of putting something else in there. Pleuritis, also known as pleurisy. That's basically when these membranes get inflamed for whatever reason. It could be due to cancer, it could be due to pneumonia, trauma, anything that's going to make those layers thicken. And when they do, they start rubbing against each other, and that's what I was explaining to you, that you can put a stethoscope in someone who's got pleurisy, or pleuritis, and you can hear these what we call friction rubs. Friction rubs is that thing I was telling you about when you step in snow. Boom, boom, boom. That's what it sounds like. And they have a lot of pain because these two areas, these two layers are inflamed. They get irritated when you inhale or exhale. It's rubbing against something that's very painful, and that's what's causing that. You get a pleural fusion. For some reason, the lining of these layers are making too much fluid out there, and it's going to make the space become wider and wider. And that's going to compromise the amount of air that you can be breathing in and out. So it's accumulation of fluid due to inflammation. All right? We could also have air in there. Okay, well, I'm sorry, hemothorax. You could have blood in there. You fall off a ladder, or you get stabbed in the, God forbid, in the chest or whatever. Blood is then going to be pouring into this potential space and making this potential space get bigger and bigger, pressing against the lung, and the lung can't expand, and i.e. collapsed lung. Okay? And that's what's happening there. Or you could fall off a ladder, you don't puncture anything, but part of the lung, because it's full with air, some of those alveoli can burst. And now air from those areas can go into this potential space and cause what we have a pneumothorax. Now you have air in there, and it acts like a valve. Where it got punctured, it acts like a valve, or not punctured, but where the alveolus ruptures. Air can go out, but it can't come back. Air goes out into that space, but it can't go back out your mouth and breathe it out. So it's kind of like locked in there. You can't get it out. So that's what a normal thorax is. All right, so penetrating injury, or let's say your alveoli ruptures. So the best way to get rid of anything that's in that potential space is to put a hole in there and end up putting a chest tube. I'm sure you've heard of this stuff. Okay? So what you're going to do is you do this thoracocentesis, which is basically you put a needle in there and so you have the access to that space. Remove the needle and then put a tube in there and let all whatever's in there go out into the tube. Okay? So we put this chest tube insertion. So what you're doing here, before I show you the chest tube, there's a hemothorax. You can see there's blood in there, which means that it's pressing against the lung and the lung can't expand. That lung is collapsed. You can't get all the air that's supposed to go in there. Or you can have a lot of air in there, and that's going to press against the lung. Again, the air goes out, but it can't get back into the lung. So it's going to press against the lung, and the lung gets collapsed. Okay? There's another picture of a pneumothorax. So what you do with something like this, you find an area that's the lowest amount, or lowest area over here, and this is nurses, you'll be helping the doctor, or the nurse practitioner, or the PA. And you got to try and make it so that they're leaning forward so we can actually make the spaces in between the ribs a little bit wider to work with. Once you have that, the medical professional will put a needle in here, in the lowest part, there's the lung tissue, in the lowest part over here, take the needle out and then put a chest tube in here to make it go into a bag. So if there's going to be blood, all the blood will pour into there, allowing the lung to expand. If this is air in here, then we're going to put it in a bag full of water. And if the air goes into the water, what are we going to see? Bubbles. All right? So the bubbles will go in there. It means all the air is escaping from there. And that can take anywhere from 7 to 10 days for all the air to stay out, and you'll start seeing no more bubbles forming in it. And you know that there's no more air there. Okay? Questions about it? And that, meanwhile, the lung is expanding and expanding and expanding. Okay? Now, that brings up mesothelioma. Okay? You see this on the TV and stuff. Mesothelioma is not lung cancer. And I think a lot of TV is actually trying to mislead the public, okay? It leads to lung cancer if it's not treated, but it's not lung cancer. Mesothelioma is basically cancer of the parietal and visceral layers, okay? So it's a rare cancer, very rare. Usually we see it with people who are exposed for chronic times with asbestos, okay? Now I just found out about a year ago, I just assumed everybody knew what asbestos is, and I was shocked that nobody doesn't know what asbestos is. Raise your hand if you know what asbestos is. Yeah, 2 out of 7. Okay, so let me just explain what asbestos is. Asbestos is something that was added to buildings back in the 1920s, 1930s or so, because asbestos is this, I wouldn't say it's a chemical, it's an element, it's a substance that they add to paint, that they add to plaster. And what's nice about this, if there is something nice, it doesn't catch on fire. So this was nice at that time. Hey, why don't we just add it to certain things to houses so the houses don't burn down? The problem is, about 20, 30 years later, when these people were living in these houses for a long time, little micro areas of this asbestos goes into the air, and they're breathing it for about 20 or 30 years. As they're breathing it in, it actually caused cancer to the lining of the lungs. That's why it's over there. You just breathing in asbestos in one day, you're not going to get cancer because of the one day. It's like if you smoke, not that I endorse this, but if you smoke one cigarette, you're not going to get cancer from that one cigarette. Does that make sense? It's the chronic exposure of these items that can cause cancer. Okay? And that's what was happening. So that's what was happening. We don't see much of the asbestos now. Although a lot of buildings are still asbestos, and if you're trying to buy a house, they have to legally tell you that there is asbestos in the house. It's up to you if you want to get rid of it or not. Okay? So that's what's happening there. But it can occur, the mesothelioma can occur in the pericardium, peritoneum, testicles, because it's anywhere. And like I said, asbestos is just one cause of it. There's many reasons that you would get mesothelioma. But because you have visceral and parietal layers in these other areas here, you could get it there too. It's just that when you breathe in asbestos, we see it a lot more in the lung area. And if it's left untreated, it could spread to the lungs themselves. And that's where you get the lung cancer. Okay. Most common type of lung cancer that someone has is metastases. I don't know if you know that or not. All right. Most commonplace, or the most common form of lung cancer is not primary lung cancer that started from the lungs. It started from someplace else. When someone has lung cancer, they're looking other places. But the biopsy would tell you if it was from someplace else or it came right from the lung.